So we'll be discussing today imaging in head neck cancers. Predominantly, I'll discuss the anatomy, and let's make it interactive this time because we've had this lecture a couple of times. At least the seniors have had it many times. So for the interest of the first years, that where to do this kind of imaging. And when it comes to soft tissue, you need the high resolution and better contrast, differentiating between soft tissues and the muscle per se, like the extrinsic and the intrinsic muscle. So there you need high soft tissue contrast. So what would you advocate for you in such scenarios where you need high soft tissue contrast, CT or MRI? MR. For base of tongue, what would you do? MR. So imaging is not done to diagnose. Remember, imaging is not done to diagnose a malignancy in oral cavity. Only and only it is done for diagnosing a malignancy is when the mouth opening is zero. That means there is ankyloglossia. You cannot look into the oral cavity, and that's the only reason where you would like to rule out the cause for ankyloglossia and look for any malignancy. But otherwise, per se, imaging is not done for diagnosis. So you are not liable to pick up a disease, like if there's a subtle buccal mucosal thickening or a small volume disease which you're not appreciating but the clinician has found, that doesn't mean that you are missing on something. You go back, see the clinical findings and look for that. But basically imaging is done to look for the extent of disease, resectability, whether it is resectable or unresectable. If it is resectable, what is the extent of disease? So that is the interest of the clinician's interest in getting the imaging done. The second most important thing is certain structures are not seen on clinical examination, such as the clinicians cannot evaluate the thyroid cartilages, they cannot look into the Pterygopalatine fossa, they cannot look beyond RMT, fetal involvement. The bones are not seen on clinical examination. So these are the areas which may alter the plan of management, and they are seen only on imaging. So that's another add-on. So that basically you are planning treatment, but you're not diagnosing the disease. And third thing is end staging, which by and large we as radiologists feel that it's very important, but with clinicians per se they do ipsilateral neck dissection in all head neck cancers per se. And if patient is a candidate for chemoradiotherapy, bilateral necks are always radiated. So picking up neck on the node on the ipsilateral side is not that important from a clinician's perspective. But what the clinician would like to know is whether there is any contralateral nodal disease. That means you have picked a contralateral node which will definitely alter the management. That means the patient would require a contralateral either radiotherapy or a neck dissection. And when you pick a node, we'll go into the depth of each and every area. But when you pick a node, it's not just that you say that you've picked a metastatic node. You have to tell whether this metastatic node, how is it? How are the relationship of this node with the adjacent viscera? Whether this node is resectable or unresectable. So anything, your report should be such that at the end of the day, you should tell clinician, can you resect this disease, the primary and the nodal disease? Whether this is a candidate for definitive treatment or not, or this patient is a candidate for palliative treatment. So various imaging techniques available, we'll see as and when they will come CT, MR. I don't want to go into the depth of it, and we've seen that the areas of interest which the report should include is the bone and the cartilage involvement, perineural and the nodal involvement. These are the ones which are changing the management. So basically the neck is divided from the perspective of reporting as well as considering the diseases in the head neck into three parts: the suprahyoid neck and the infrahyoid neck and the base skull. So these are the three compartments which are different in terms of their presentation, their disease extension and their management also. So suprahyoid neck disease basically are the oral cavity diseases and the tongue malignancies. The oral cavity per se, they are predominantly treated by surgery. The main or tongue proper is treated by surgery. The base tongue BOT, that is by CTRT. Skull-based diseases are managed differently. They are entirely their management is entirely different, and their presentation and the kind of lesions which you see is entirely different, which Amit will be covering next week. And infrahead neck constitutes the supraglottis, hypopharynx, and larynx. So there the management is again different. I know you've seen scans happening in Tata, and then you've seen this puff cheek happening all the time, but it's not a routine norm in the outside Tata. Like if you go Not many hospitals would be using this protocol of doing a puff check, and puff check is very important. If you've landed up in a situation, I have seen a couple of times you've asked for a bone algorithm CT, like a scanogram for a patient who's had outside imaging, and you see that the cheek is abutting the gingival mucosa, and you cannot appreciate the buccal mucosal thickening. So puff cheek technique is very, very, very important when you are dealing with oral cavity diseases. Uh, uh, Basically, the imaging of the oral cavity for the buccal, it's the NBCT. Reason being, the chances of having bone involvement in buccal CT is upwards of 30%, which is less than 5% in tongue malignancy. So at baseline presentation, the if you see the number of cases, if you see 100 cases of buccal mucosa, 30 cases will have mandibular involvement, and only 5 cases of tongue will have mandibular involvement. So there, the CT becomes an adjunct to the tongue if you are in doubt. But in buccal, the main change in the management would be based on the mandibular bone involvement or a maxillary bone involvement, and there you need CT because subtle cortical erosions or even deeper cortical erosions would change the management of the patient. For Bascal, again, I would say CT and MR both are complementary. So you see that you've done a comprehensive imaging. When you are looking at the foramens, you've seen the widening, the subtle destruction, subtle erosions of the cortices along the clivus, along the foramens, subtle widening. You've picked on CT, but to make a definitive diagnosis of perineal spread or extension into the intracranial cavity, you must and must advocate an MRI. There's no harm in asking an additional imaging when you are not sure. So always and always ask for an additional imaging when you are not sure, especially when you are when the plan is going to change from resectable disease at the foramina veil to unresectable disease when it goes into the cavernous sinus. For the infrahyoid neck, by and large, we use MDCT. The reason being, we're very comfortable with doing this in the hypopharynx and larynx. Less artifacts, you can acquire the imaging in a very short span of time, and the swallowing artifacts do not interfere with the acquisition. Uh, I would say that MR is coming up in a big way. The protocols are not standardized, but once they are standardized and with the ultra high fast MRs, the larynx imaging would be replaced by MR. And we see quite a lot of cases these days where there is subtle paraglottic invasion, or there is the cartilage is not ossified, young adult where the cartilages are still not ossified, and there you find it difficult to differentiate between cartilage erosion and because the cartilage is not ossified, there is no concept of erosion or invasion. The white line of cartilage is just seen. So there MR would be an adjunct. So coming to the puff cheek technique, what do you see in a puff cheek technique? You see the buccal mucosa over here, the upper and the lower gingival surfaces, the hard palate, the oral tongue proper, and the floor of the mouth. So these are the 4 or 5 areas where the malignancies would arise. This is the buccinator complex or the buccal mucosa, where the disease would arise, and it will go up either into the upper gingiva or to the lower gingiva. So remember that the predominant population in our country is that khena and gutka chewers. So what they do is they keep a pocket of this kheni or whatever gutka at the RMT region along the close to the premolars. So they usually keep it in the lower side. So you see most of the diseases into the lower RMT, lower gingivobuccal sulcus, close to the premolar area. And by and large, these patients, because they are gutka chewers, their dental hygiene is very poor. They have add-on periodontitis, they may have loose tooth, they may have adentalous socket also. So all these points should be kept in mind when you are seeing. So the anatomy of that region becomes very important because that would define the extent of disease later on. Adentalous socket, because the tooth is not there within the cavity, gives way for the gingival disease to go into the alveolar socket and lead to mandibular indirect invasion. So these things are very important that you look at that particular site carefully. Uh, Again, you guys are very well versed that there are 3 windows to be used: soft tissue, bone window, and bone algorithms. This is like how they look, but remember, always and always try to reformat. Try to look for subtle erosions. Reformat in the bone algorithm. Have a superficial look that you're not missing on any erosion or any canal involvement or any destruction of the bone. Especially, I have seen that I go back in the nasopharynx cases. I go back to the PET CT, open the CT scan, and try to look for subtle clival erosion which are not otherwise picked on MR. So I do not rely much on the bone involvement in nasopharynx until there is gross marrow invasion. So if you're not seeing gross marrow invasion, go back into the PET CT, because PET is usually done within a couple of days time with the MR. So go back and see, look for subtle erosion along the clivus, along the sphenoid bone, that you will pick better on the CT than on the MRI. Apart from this, bone algorithm is also important into the temporal bone and the internal aortic canal assessment. So that's another area where you need bone algorithm. So, coming to oblique reformats, I don't know how many of you routinely do oblique reformats, but it doesn't take more than 3 to 4 minutes to see the scan into oblique reformats. So, oblique reformats come handy when you are trying to look for erosions or smooth cortication along the adentulous socket. So, when there is tooth loss, a smooth cortication due to bone resorption takes place. That should not be mistaken as uh, bone invasion. So you use bone algorithm, do oblique reformats, and look for whether it is permeative pattern or it is smooth corticated. So here you see that there is smooth cortication over here. There is a slight like kind of cavity over here, but this is due to tooth loss. And there is permeative pattern which is going deep. So there are variable levels of permeative pattern. It can be very early, like seen in the first case, where there is subtle uh, uh, toothing and wedging has taken place. This is going deep into the marrow, and this is going deep up to the inferior alveolar canal. So these things you can only appreciate on a oblique reformat. So why inferior alveolar canal is important? So you have to understand that the bone is involved from the outer cortex. It has gone into the marrow, and then the disease may reach up to the inferior alveolar canal, into the, that is the mandibular canal, which holds the inferior alveolar nerve, and go up to the, for it can go along the mandibular nerve into the intracranial cavity. So a disease which may be localized to the lower GPS can have extension into the intracranial cavity. So you have actually total alteration of the plan of management. From the radiotherapy perspective, this is the organ at risk. The terminology which radiotherapists use is called as the organ at risk. Organ at risk means which are the organs to be preserved when you are giving radiotherapy. So when the radiotherapist would come and discuss the case with you, his key interest is not detecting the disease. He'll ask you to delineate the disease, but his key interest will also be to preserve the normal structure, so that not to give extra radiation to adjacent structure. So what could be those structures? Gurtej, what could be the structures at the skull base which a radiotherapist would want to exclude from the field of radiotherapy, not to give a radiotherapy to that particular area? What do you think? Some important structure at the base skull. Mahesh? Mayur? Pituitary gland, okay. Okay, first year. Zeba? Any structure, important structure at base skull, close to cavernous sinus? Optic nerve, the most important structure. You have to preserve the eyesight. You cannot give extra radiation. Why this IMRT and external beam, EBRTs have come into play? Because you want to give targeted, dedicated field radiotherapy. You don't want to irradiate brainstem. When you have disease extending up to the perineural, extending up to the ganglia, you want to preserve the brainstem. You don't want to give high doses there. Internal aortic canal. These are structures where you would not want to give radiotherapy, because you will cause morbidity. So starting from the cranial most part, you have the superior orbital fissure. The superior orbital fissures open laterally. They are the lateral opening of the orbital apex, and medial opening forms the optic canal. So there are two openings at the orbital apex. The lateral opening is the, and the medial one is the, okay. So these are the two structures which are perpendicularly placed, like they are oblique at some angle, but the medial ones are the optic canal and the lateral ones are the superior orbital fissure. As you go further down, you will see that the little bit caudal, you will see the cavernous sinus, and close to the cavernous sinus, at that level, when you see the cavernous sinus, you will have the internal auditory canal, the important structure posteriorly, and the inferior orbital fissure. So this is the inferior orbital fissure over here, which will open into the again into the intracranial cavity. This temporal bone will be a separate lecture. So I will go directly to the Pterygopalatine fossa to explain you what is Pterygopalatine fossa. I just found this image from net, which has very well described the anatomy. So this is from Radiopedia. If you want to know this, you go back and see this image, read it well. So what is Pterygopalatine fossa? It's an inverted pyramidal structure, and why it is important? It's the structure in the oral in the head and neck, which is the most important structure guiding the management, guiding perineural spread into the areas where you cannot resect the disease. So basically, the disease along the nerves can go into the intracranial cavity through here. The disease from the buccal mucosa can go into the intracranial cavity through this fossa. The disease from the nasal cavity can go deep into the intracranial cavity through this fossa. So the posterior wall is made by the pterygoid plates. I will show you on this. So basically, this is the pterygopalatine fossa, the medially placed inverted. This is one bit of it. This is an axial cut through the pterygopalatine fossa. So anteriorly, you see the maxillary wall and the pterygoid plates. Posteriorly, you see the palatine bone. Medially, you see the part of the palatine bone over here. Laterally, it is opening into the pterygomaxillary fissure. And between the palatine bone and this is the part of the sphenoid bone. So this is the sphenopalatine foramen. So medially it opens into the sphenopalatine foramen, laterally it opens into the pterygomaxillary fissure, anteriorly it will open into the nasal cavity and the nasopharynx, and posteriorly it will have multiple openings. So posteriorly it can open into the foramen rotundum, it can open into the median canal, and it can open into the inferior orbital fissure, depending at which level you are. So posterior openings are multiple. An anterior opening into the nasopharynx, and lateral opening into the pterygomaxillary fissure, and medial opening into the sphenopalatine foramen and the nasal cavity proper. So someone has to repeat now. Koi first theory. Zeba? If you understood in this 5 minutes, then I will be surprised. But come here. What is the structure actually?
Pterygopalatine
Fossa. What is it?
inverted
Pyramidal space.
Anteriorly it will open into the maxillary antrum
Maxillary. Okay.
and maxillaries. Laterally,
So what's
medially
up?
sphenopalatine.
Tell madam.
So medially it will open into nasal cavity and sphenopalatine.
Tell her what is pterygopalatine fossa. What you understood.
Pterygopalatine fossa is a junction of many nerves actually passing through this route. It is important because the involvement of this space can lead to perinodal extension to other important structures in the base of skull. So that it has actually six openings, 6 routes through which it can split. So medially it
So
can.
I'll explain in a very simple manner. Imagine a three-dimensional structure. Imagine that there is a hard palate, so that becomes the floor of the pterygopalatine fossa. Okay, like partly, and at the hard palate where you see the pterygopalatine fossa, there is lesser palatine foramen, greater palatine foramen. So two foramens in the floor. Okay, that opens like a pyramid now. Okay? The pyramid is opening up and it goes up. So anteriorly there will be greater palatine foramen. Okay, between the anterior to the pterygoid plates. So there are two pterygoid plates. Anteriorly small foramen you will see, which is the greater palatine foramen. The greater palatine foramen is along the lateral wall of the nasal cavity. Okay, the nasal cavity is like this. The greater palatine foramen is like this. Posteriorly there are two pterygoid plates. So between this structure, the space is there. This particular medial wall is by the palatine bone. Okay, palatine process. Anteriorly there are pterygoid plates. Anterior to that is the greater palatine foramen. But the floor, which is the hard palate, had the greater palatine foramen, the palatine foramens. Okay, so there are two foramens at the base, at the floor. When you start moving up, the lateral part will open into the infratemporal fossa. Through what? Through pterygomaxillary fissure. Okay. So the lateral part is opening into the pterygomaxillary fissure into the infratemporal fossa. Medial part is opening through the sphenopalatine foramen into the nasal cavity. Posterior, now you come. Tell me what all you will see posteriorly. At different levels, you will see different things. Pterygoid canal is equivalent to anybody? Median canal. So pterygoid canal and superior to that at the foramen rotundum. So there are two important structures which will open the pterygoid canal and the foramen rotundum. And anteriorly it will open into the inferior orbital fissure. We'll see a coronal image how it opens anteriorly into the inferior orbital fissure. So the important foramens which you start seeing from the base skull, name them. The three foramens at the base skull. जिनके आगे फोरामेन लगा है, ऐसे तीन वर्ड बता दो मुझे स्कल बेस पे.
Foramen oval, foramen rotundum.
Saket, you come forward, not to be seen only. Tell.
Foramen oval, foramen rotundum, foramen spinosum.
And one more. Which is not hosting any nerve, but just like a foramen. Named like a foramen, but like there is no nerve in that. Foramen lacrum. So let's identify the oval is the oval structure, foramen oval. Posterior to that is the foramen spinosum, and the L-shaped longitudinal foramen is the foramen lacrum. What is the content of foramen lacrum? Delnas?
It is closed inferiorly by a cartilage which holds the internal artery.
And if it is deficient, it can lead to? It can mimic like which particular malignancy? Glomus. Yeah. So if there is deficiency of the foramen lacrum, if it is there is no cartilaginous floor, then it can lead to, it can mimic like a glomus malignancy. The pulsations would be seen in the inner ear. On the coronal section, the medially placed ones, this is how the coronal structure, coronal view would look. So at this level, when you see the sphenoid sinuses and the nasopharynx opening into the nasal cavity opening into the nasopharynx proper, at this section you have to identify few important landmarks again. The first and foremost being the optic canal. The optic canal, the superior most part, like a cup C, inverted cup, which is placed over here. So this hosts the optic nerve, that is the optic canal. This particular part is along the lateral wall of the sphenoid sinus is the superior orbital fissure. The superior orbital fissure will come down, and then you will see two rounded structures, one within the bone, one on the lateral side. The lateral one is the foramen rotundum, and the medial one is the median canal. So the medial is the, so there are total 1, 2, 3, 4 structures are there. The topmost being the optic canal, the lateral wall of the sphenoid, like a parallel to the lateral wall of the sphenoid sinus, is the superior orbital fissure. And if you go inferiorly, the floor of the superior orbital fissure, there will be a foramen on the lateral aspect, which will be foramen rotundum, and the medial rounded foramen would be median canal. So let's see, as we discussed that this Pterygopalatine fossa is very important. This is how it will open. So this will open into the parotid space and the infratemporal, parapharyngeal space and the infratemporal fossa onto the lateral side, the nasal cavity into the medial side. Even the superior orbital fissure can get involved into the superior aspect, and the inferiorly it can go into the lower infratemporal fossa also. So diseases of the nasopharynx will use this route to come into masticator space. Diseases of the buccal cavity would use masticator space and then infratemporal fossa and intracranial. Disease of the skull base would also use the same route inferiorly. So you have to find this route of extension using this Pterygopalatine fossa. Coming to the other important foramens, the foramen greater palatine and the lesser palatine. So try to reformat, take the cursor on the bone window, put it on the greater palatine foramen today, and see it on coronal sach, and see how they open into the Pterygopalatine fossa. So this is the, you see that we are somewhere in the mid sagittal section, and this is the greater palatine foramen, which is opening again into the Pterygopalatine fossa reaching up to the inferior orbital fissure. So this is into the extending up to the orbit. This is the little bit laterally placed. There can be multiple lesser palatine foramens. You can have aberrant lesser palatine foramens where there can be 2 or 3 also multiple lesser palatine foramens. So this is the lesser palatine foramen again reaching up to the pterygopalatine fossa. As we go, we see the axial cuts. So this is the pterygomaxillary fissure. Medially, as I said, this is the sphenopalatine foramen which is opening medially, and posteriorly it is opening into the median canal. So the median canal is a thin slit structure, more medially placed, and the foramen rotundum will be laterally placed, because we saw on the coronal the foramen rotundum was lateral and the median canal was medial. So the all remember that what is the medial most canal which you will see would be the median canal, which will be next to it would be the foramen rotundum. So I try to identify first the medial most canal and label it as the median canal. Another key point to identify median canal is the median canal opens into the foramen lacerum, and the foramen rotundum will open into the temporal fossa, like the medial temporal cranial cavity. So you see over here the median canal is opening into the foramen lacerum. So that's another way to identify median canal. So if in doubt, sometimes you may have asymmetry, you are not finding it and the cut is not there. Try to identify which canal is opening into the foramen lacerum, and that canal is median canal. So now it becomes very important that why this story we build up. We saw that let's say there was a disease in the mandible, and it went up to the mandibular foramen. Then you saw the disease between the pterygoid muscles. It reached up to the pterygomaxillary fissure, and now it has involved the pterygopalatine fossa. Now you are seeing some enhancement along the median canal, and patient has hypoglossal nerve palsy. So this is the route of spread. The median canal will get involved. It will involve the foramen lacerum, which is closely placed to the jugular foramen. Just posterior to it is the jugular foramen, and next to it is the hypoglossal canal. So the route of extent of perineural can be distant to up till jugular foramen. Remember. So look into the history. Try to look for what kind of history the patient has given, and look for the perineural spread along that particular pathway. Uh, so these are the ones which I said, the greater palatine foramen, which is along the medial nasal, the medial wall of the maxillary sinus and the lateral wall of the nasal cavity. Try to reconstruct them, and this is the lesser palatine foramen. So they are closely placed. Lesser palatine not so important, but greater palatine foramen is very important, because that nerve gets that's larger and appreciable, and then you can document whether there is perineural along it. But by and large, greater palatine perineural is only seen on MRI, not very well seen on CT. So this was again the coronal section of the pterygopalatine fossa. We saw that it was opening into the infratemporal fossa, but just to highlight how it goes into the inferior orbital fissure. So this is the anterior part of the inferior orbital fissure, and it is extending into the inferior orbital fissure along the pterygopalatine fossa. So, sorry. As I said that we saw the median canal, which was opening into foramen lacerum, and more cranially when you will see another way to identify so median canal you identified at the level of median canal will be at the level of foramen lacerum, foramen ovale, foramen spinosum. It will open into the foramen lacerum. Foramen rotundum will be at the level of the cone, ice cream cone, at the internal auditory canal. So try to see that you are seeing the ice cream cone, a bit of the internal ear, and it is opening into the. What is this structure, madam?
Median
Median canal. Where did I tell median canal will open?
canal. Foramen lacerum.
Foramen lacerum. And then what I am not talking, which structure I was describing right now? Foramen rotundum. Thank God you are with us. Or कौन है first year? Some first year come forward. Gurtej and Gurtej. What is this? Opening into. It's at the level of Meckel's cave. It's at the level of the trigeminal ganglion. It will open posteriorly close to the trigeminal ganglion, will take a route and go into the brainstem. So you have to see the disease spread all along the trigeminal ganglion up to the brainstem. That is the level of the foramen rotundum. Lastly, this is a structure that I said, like you can have the cord-like structure reaching up to the foramen ovale. And this is an example where you have a disease. It has opened, involved the pterygopalatine fossa, and it is extending along now. Which structure is this? Hmm? Median canal. More medially placed, it will be median canal. So coming to the, we've seen the foramens now. Coming to the important muscles, the pterygoid muscles and the pterygoid plates. So why pterygoid muscles are important? The lateral pterygoid forms the floor of the topmost point or the roof of the infratemporal fossa. Once you resect in lateral pterygoid, you do not have anything to hold the base skull. So if you see on the coronal, if you resect this muscle over here, there's nothing to patch up into the base skull. So you need this muscle. This muscle is kind of the flow, the soft tissue of the floor of the base skull. So that is the reason they don't resect the lateral pterygoid muscle. So the lateral pterygoid muscles forms the high infratemporal part of the high infratemporal fossa, and the medial pterygoid would form the part of the low or the resectable infratemporal fossa. So the lateral will take origin from the lateral pterygoid plate, and the medial will take origin from the medial pterygoid plate. Reba, understand? Gurtej, lateral take origin from? It will be more horizontal. It will it will attach onto the ramus of the mandible. The medial will be more vertical. It will go and attach to the main body of the mandible. Apart, so this is the medial pterygoid muscle, which is more vertical. So the medial pterygoid is between the two pterygoid plates, taking origin from the medial pterygoid plate, more vertically placed, will attach to the body of the mandible, will go inferiorly. The lateral pterygoid will be more horizontal, will take origin from the lateral pterygoid plate, will be on the outer aspect of the lateral pterygoid plate, will insert into the ramus of the mandible. Other important muscle which forms the floor of the mouth is the mylohyoid sling, which is like a sling shaped muscle, and you can appreciate that. Below the sling shaped muscle is the सभी chorus मत करो. Okay. So now let's identify, because the second years have seen the spaces enough over a period of time. Mayuresh, which is this space, Mayuresh? टेम्पोरालिस मसल. मैंने पूछा स्पेस कौन सा है. Zeba come show us temporalis muscle. Can you see temporalis in this section? Tell the origin of temporalis muscle and insertion of temporalis muscle. कहाँ कौन सी space? The one that where is this temporalis coming from? किसने prompt किया है? Posterior to that. So what are the contents of buccal space? Parotid duct,
zygomaticus
major muscle,
buccinator muscle,
and the buccal fat and the buccal mucosa. That forms the buccinator complex. So basically, the disease will arise in the buccinator complex, which is the buccinator muscle. That is the only importance of the buccal space. Otherwise, you don't use this terminology at all. This is a radiological space, not used by the clinicians at all. So you don't interact in this particular format. Buccal space is involved. Posterior to that is what? Second year or Kanaya? What is this?
Masticator space.
The contents of masticator space?
Masseter, medial pterygoid,
Masseter.
and lateral pterygoid, medial pterygoid.
एक करके पिक करो. कौन सी पिक करना चाह रहे हो?
So mandible, masseter,
Mandible, masseter,
medial and lateral pterygoid.
medial and lateral pterygoid. So masticator space has mandible, masseter, medial and lateral pterygoid. Posterior to that, simple one, Zeba, you can tell us what is this structure? Parotid. So parotid forms the parotid space and it extends into the deep parotid region also. You see that there is a tongue-like structure which is going deeper through the stylomastoid foramen. It is the stylomandibular foramen, that is a deep lobe of the parotid and that is also part of the parotid space. Mayur, what is this? This space? इसको तो मैंने क्यूपिड बो के लिए भेजा था ना, कौन था क्यूपिड बो वाला? दिस क्यूपिड बो पेरेंट्स कौन था वो क्यूपिड बो जाके देख के भी आया था? नहीं मतलब बहुत डिस्कशन हुई हमारी क्यूपिड बो पे कि कहाँ होता है क्यूपिड बो फिर इसने बताया कि कहाँ है, यहाँ होता है. There were many, but he knew. So what is Cupid bow now? You will tell everybody. Literal and otherwise also. Enlighten people.
Angel arrow like
Angel arrow लेके क्या कर रहा है? This is also getting recorded, huh?
Who's Alex Isaac?
See, you should rather say, Arjun Bo or something. Then India might become very famous.
Today's homework is to go back and say Cupid bow. Time is soon coming soon. Within a month's time, it will help you out. 28 days. Lata's birthday. Yeah. So okay, so this is the retropharyngeal space, and these are the prevertebral muscles over here. Longus colli. Remember, many people would, if I'll ask what is the content of the prevertebral region, it's the longus colli. This is the longus colli muscle. Medially, it's the pharyngeal mucosal space, and the lateral to the pharyngeal mucosal space is the parapharyngeal space, which is divided into two parts. The anterior fat-containing space is the pre-styloid parapharyngeal space proper, and the posterior one, which hosts the carotid artery and post-styloid or the carotid space. So remember, understood? Starting from here, the buccal space, masticator space, parotid space, parapharyngeal space, carotid space, pharyngeal mucosal space, and retropharyngeal space. Okay? Now, only space which get altered between the radiologist and the clinician is the masticator space. So the masticator space and the parapharyngeal space, their combination is different for the surgeon. Why parapharyngeal space, why you have to differentiate between pharyngeal mucosal space and parapharyngeal spaces? The parapharyngeal space involvement is a T3 disease in nasopharynx, whereas the origin of the disease for the nasopharynx is from the parapharyngeal mucosal space. The parapharyngeal mucosal space will give origin to the disease that is bounded by the pharyngobasilar fascia. So this is the fascia over here, that is the pharyngobasilar fascia, which is very well seen on MR. The moment there is breach of this fascia and involvement of the fat, that is the involvement of the parapharyngeal space fat. Usually you will see that the once the space gets involved, the extension would be like a inverted, like a Y shape. So because this, only the fat will get involved. So when you see a T3 disease, you will see the enhancement which is like a Y limb, two Y limbs which is going along the prevertebral region and along the pharyngobasilar fascia, extending into the fat of the parapharyngeal space. So that is the T3 disease in nasopharynx. Again, parapharyngeal space is another important space. Once it gets involved, it opens channels into multiple spaces, anteriorly into the masticator space, laterally into the parotid space, medially into the pharyngeal mucosal space, and posteriorly into the carotid space. So patients may have vagal nerve palsy, may present with vocal cord palsy. Look for carotid space involvement. Patients with carotid body tumor may again have features of parapharyngeal space invasion, aggressive ones, and the disease over here open into multiple spaces. Pharyngeal mucosa. And the last one is the perivertebral space. So this perivertebral space can be paravertebral and posterior perivertebral spaces. The only thing why I like the perivertebral space is when the perivertebral space is involved, look for the involvement of the vertebral artery. The vertebral artery, when it comes to the out of the foramen transversarium, it is in close contact with the paravertebral muscles. And when there is a nodal disease at the parotid space, it can involve the vertebral artery and make the disease unresectable. So you have to be very careful when you are looking for invasion of the perivertebral space. Coming to the most important part, the second most important part apart from the Pterygopalatine fossa is the infratemporal fossa. So I think by and large everybody should know this, and if you are in Tata, you should be the ones when you join some other center, teach people what is infratemporal fossa in depth, and people should get mesmerized by you that you know infratemporal fossa so well. So infratemporal, it's overhyped thing. I think it's just a very simple subject. There are a few parts which are part of the infratemporal fossa and not part of the masticator space. Remember, the infratemporal fossa is medial to the inner border of the mandible. Mandible is not part of the infratemporal fossa. Okay, it's only the soft tissue containing space. The only bone in the infratemporal fossa is the pterygoid plate. The only bone in the infratemporal fossa is the pterygoid plate. It extends from the pharyngeal mucosal space up to the medial wall of the mandible. So what all structures you will see when you go from the pharyngeal mucosal space up to the medial wall of the mandible? You will see the pharyngeal mucosal space, the parapharyngeal fat, then you will see the medial pterygoid or the lateral pterygoid depending on which level you are, and then the medial wall of the mandible. That's it. It ends there. Now, if I take out the parapharyngeal space, so I started from the pharyngeal mucosal space, I included the fat of the parapharyngeal space, included the medial and the lateral pterygoid muscles, and reached up to the medial wall of the mandible, some bit of the fat in the retroentral space also. This is the maxillary antrum, this is the fat in the retroentral space. So, whatever was there in that area we included and we formed the infratemporal fossa. Now, if I exclude the parapharyngeal space, but I include the mandible and the masseter, then it becomes the masticator space. So, masticator space had masseter and mandible and medial pterygoid and lateral pterygoid. The only extra thing in there are all M's and one lateral pterygoid in it. So, masseter, mandible, medial pterygoid and lateral pterygoid. But in the infratemporal fossa, you are excluding the masseter and the mandible, but you are including parapharyngeal space and the pharyngeal mucosal space also. So remember this. Everybody's clear?
But how should we then report it? Like if it's high ITF involvement and the coronal process is only thing.
I knew it was coming.
So
Yeah. So remember the coronal process. My take on this is like disease is not like black and white. It does not end there only. Okay. When I see temporalis muscle which are bulky, they don't end till my eyes are seeing. They have a margin up and down. So if the coronal process is involved, I'm coming to that next section. So this is on the coronal section, how it is in the boundary. The masseter muscle on the outer aspect of the mandible proper, the two pterygoids, the lateral pterygoid and the medial pterygoid. The more horizontal is the lateral pterygoid, the one which is vertical is the medial pterygoid. And if you include the pharyngeal mucosal space and the parapharyngeal space fat, it becomes the infratemporal fossa. This is again a diagrammatic representation. So this is what we use as the landmark. Somebody the other day told me that do a reformat and reach on the. Sometimes you have obliquity. You said it, na? It was a very good point. Can you tell them?
No, because sometimes the angle in which they have taken the actions, you can see mandibular notch at any level, but in sagittal you cannot manipulate it. It cannot come higher or lower. So if you want to see exactly if it is reaching above the mandibular notch or not, you should see it on sagittal.
So everybody understood.
If you have any confusion,
like if you kept the neck like this, the cut of the how you acquire may be different than the notch is like getting altered. You see depending on the angle at which you have acquired. But on the sagittal, the notch will not get altered at all. So you take your cursor on the sagittal if you are in doubt and see whether the disease is going above that level or not. If you are in doubt, if the acquisition, the only two areas where the acquisition may change the whole thing is at the larynx when you have thyroid cartilage, the paraglottic space, and at the sigmoid notch. So there, if you are in doubt, the acquisition is not proper, then you use the coronal in the larynx and sagittal in the notch left. So this is the sub notch. Any disease above the sigmoid notch is disease extending into the high infratemporal fossa. The anterior part of the notch is the coronary process. I per se, if a coronary process is involved, I call it infratemporal fossa involvement, high ITF involvement, because the coronary process, when it is disrupted, it is eroded, it throws disease along the medial side also. So it forms the part of the infratemporal fossa. It is high ITF and it is the temporalis muscle inserts close to the coronary process. So it's very difficult to have negative margins in this area. This concept I've already explained. I think we end here and then RMT and tongue will do sometime later. Any doubts? Give Zeba some 2-3 cases today. See whether she is.
Pre-vertebral and retropharyngeal spaces are the same?
Repeat the question and then answer. Yeah? Repeat the question and then answer, then it can be heard on the laptop.
Acha.
Retropharyngeal space and pre-vertebral spaces are synonymous, or?
So retropharyngeal space and prevertebral spaces are synonymous in the suprahyoid neck. When you go deeper in the infrahyoid neck, the prevertebral space also includes the paravertebral spaces, also part of the paravertebral spaces. Retropharyngeal space is only limited to the reporting of the nasopharynx, where you are looking for retropharyngeal nodes, and it is commonly used terminology in the suprahyoid neck. The infrahyoid neck, you use the prevertebral space, because there the retropharyngeal space is merging into the prevertebral space, and that is the prevertebral space proper. So the terminology ends, the retropharyngeal space terminology ends at the level of the cricoid region. Anything superior to that is the retropharyngeal space, below that is the prevertebral space. Which one? Cupid.
Perivertebral will include prevertebral
And paravertebral, both.
So retropharyngeal node, even if it is like fire.
Any node in the retropharyngeal space is significant node. Nodes are not seen in the retropharyngeal. Any other? So when we will discuss diseases, it may be at times tricky that you may see enhancement along the foramens. Remember that certain foramens have normal vascular structures also, and because the malignancy is close to that area, the vascular structures may have feeders which are supplying that tumor, and they can be hyper enhancement. So hyper enhancement or enhancement along the foramen does not always mean perineural disease, but seen must be reported. So we have indirect signs. I did not come to that. We have indirect. Did we pass that slide? I think we did pass. I did not discuss that slide.
बड़ा वाला जो nerve का root का spread
No.
था ना उसका.
So you have to remember there are direct signs of perineural spread. There are indirect signs of perineural spread. The direct signs could be foraminal widening, erosions, enhancement, loss of fat. Loss of fat you will see on T1. Foramen widening you will see on the CT. Not everything you will see in one imaging only, but you have to see all. Thickened nerve and the perineural enhancement along that full course is the definitive sign. But if you see enhancement, focal enhancement or suspicious, like sometimes cavernous also is like very hyper enhancing. It can be due to the hypervascularization. It can be due to hypervascularity along the feeders. So we have seen some cases where you have foramen rotundum or foramen ovale mild hyper enhancement, but that is due to the feeders which are along that particular foramen. So it need not always be true, especially even in parotid malignancies you can have hyper enhancement along the nerve, which is actually because you're trying to look for retromandibular vein. There can be feeders and draining veins along that area which can mimic like a perineural. So hyper enhancement along the nerve course is suspicious but not a definitive sign. Late signs are atrophy, contrast enhancement and prolonged T2 hyperintensity. So what happens is once there is denervation changes, the muscles undergo denervation and then there is pseudovascularization these muscles will be hyper intense. They will, in the initial phases, they'll enhance more. Once they undergo complete atrophy, they'll stop enhancing. So these are the indirect signs. So try to look for, when you are suspecting hypoglossal nerve palsy, hemi-tongue will be atrophic. It will show T2 changes. There will be fatty replacement. Those kind of changes should always look for. Like medial pterygoid and lateral pterygoid muscles in trigeminal nerve involvement will be atrophic. There will be fatty replacement in the infratemporal fossa. Those will be indirect signs that trigeminal nerve is involved. So these are the indirect signs which you should try to look for.